Don't have a funny video to share with you today, but I do have a clinical case to share from when I was a resident at Fort Belvoir that's pertinent to this this case. I heard a couple of months ago from the class leader for the 24 TAC 1 class who's up at Belvoir, and she said she had basically the exact same case that we're going to talk about occur when she was on her inpatient rotation at Belvoir. So it kind of became very pertinent to her very early on in her phase 2 time. So I enjoy this lecture. It definitely was a head scratcher when I was taking care of this case, and I wish I had had a lecture like this before, because I would have understood what was going on better. But before we jump into that, let's just do our check on learnings, and then we'll start for the day. So this is based off of our diagnostic studies, our ancillary studies from lecture from yesterday. So which of the following statements regarding cardiac imaging is correct? Okay, here's C. Any other answers? The answer is delta. So one of the advantages of cardiac MRI is some of the scans you can actually do without using any kind of contrast agent. So that's one of the advantages. Now you can do contrast imaging studies to look for specific things, but as a hard and fast rule, you don't need contrast to do MRI. C is wrong because during nuclear imaging, technetium-99 label compounds such as susceptibility are taken up by regions of infarcted tissue but not healthy myocardium. It's the opposite. So you have to have that perfusion intact to get that radionucleotide into the tissue. So you have to have healthy tissue, or at least tissue that's getting some perfusion for that to get picked up. So that's why that one is wrong. Gadolinium is an MRI contrast. It is not a CT contrast. So that's wrong for that reason. And then pericardial thickness is more accurately measured by echo than by MRI. And basically it comes down to both are very accurate. So it's not more than. So that's why A is incorrect. All right, our next one. Which of the following is absolute contraindication for an exercise stress test? Bravo. Okay. Remember we talked about there's very few things that are absolute contraindications. There's some that are relative, but really it comes down to the absolute contraindications to do a stress test are active diseases, so active heart attacks, active endocarditis, and this is the correct answer, which of course we'll talk about what endocarditis is today. And then our last one is, which of the following is an indication for a right heart cath? Remember, right heart cath does monitoring and diagnosis. It doesn't do therapeutic stuff. So what are your thoughts? C. Okay. So assessment of filling pressures in patients with heart failure. So that's correct. So you need a left heart cath to define the coronary anatomy, because to gain access to the coronary arteries, you need to come in through just above the aortic valve. Evaluation of left ventricular function, you're going to need the left heart cath to do that. The only thing that you could get with a right heart cath is your pulmonary capillary wedge pressure, which gives you an idea of what's going on in the left atrium, but it doesn't tell you what's going on with the left ventricle. Evaluation of proximal aortic disease. Again, you're going to use a left heart cath for that. And then assessment of unstable anginal symptoms. That is a left heart cath too, because you're going to be assessing the coronary artery anatomy when you have somebody with unstable anginal symptoms. So Charlie is the correct answer for that. Okay. So recall, or let me do the clinical case scenario first. So this is when I was a third-year resident. So I was the head resident in charge of the inpatient team during the day. This patient came in overnight to the ER at Belvoir, and she was a 55-year-old postmenopausal female who presented to the ER for 3 days of fatigue low-grade fevers, and a lack of appetite. She had been previously healthy, no sick contacts. This was at the height of COVID-19. This was before the vaccine. This is when our testing for COVID-19 was pretty primitive still, where you needed at least the 2 negative tests in order to say that somebody was, in fact, negative for COVID. So she came in with these symptoms for 3 days. In the ER, she was febrile, intermittently hypotensive. She was lethargic appearing and appeared very weak. Her CBC showed a leukocytosis and a mild thrombocytopenia, and her COVID-19 test was negative at that time. She was admitted over the night to the ICU, which at Belvoir at the time, our ICU was kind of also our COVID-19 isolation area, so anybody who was suspected COVID-19 would go to the ICU. We have basically one side for real ICU patients and one side was for COVID-19 isolation patients. I arrived, or in my team, my day team, we arrived about 5 o'clock in the morning to start taking a report, and we began rounding on the team. I received a call about 30 minutes later from the lab saying that she had positive blood cultures, 3 out of 4 of the vials for gram-positive cocci in pairs and clusters, less than 10 hours after it had been drawn. Typically, when you get that kind of result, you think it's a contaminant. So the person who did the blood cultures maybe didn't use alcohol and kind of clean the skin or anything like that properly. But when I started looking at her chart, I noticed that she was having hypotensive episodes where her systolics were getting in the 80s and 90s. Periodically, she was febrile at 103. She was sinus tachycardic. So based on that kind of result, it made me suspicious that this was in fact a real blood culture result and not just a contaminant, because the clinical picture fit for positive blood cultures, right? So I went to go see her in the ICU, and the nurse commented on how she had started to develop a new rash overnight, and this is what we saw. So on the left-hand side, these were painless. On the right-hand side, this was painful. So 2 different kind of presentations to what kind of looks like a similar rash, right? And then, oh, by the way, on the feet, she was developing these little small red spots, kind of all over the feet. So we're gonna pause it there. We're gonna talk about endocarditis, and then we'll revisit kind of what happened with her case. So what exactly is infective endocarditis? So remember, when we were talking about anatomy, the endocardium is the innermost lining of the heart. It lines basically the chambers of the heart and the structures inside the chambers of the heart, and then is also then contiguous with the blood vessels. Why is that important? Well, you know, the lining itself is to prevent stuff from inside the chamber having direct contact with the myocardium, the muscle portion of the heart. So it's there as a protective barrier. It preserves the function of not only of the muscle, but also preserves the function of the blood vessels providing blood into the myocardium, but it also provides that barrier to protect the conductive system so that you have a normal electrical conduction. Well, what happens if this layer becomes damaged, becomes infected, becomes inflamed? Now you lose that protective barrier, and now that infection, that inflammation, that healing process can then affect the actual function of the myocardium, affect the function of the conduction system, or even affect the function of the blood vessels bringing blood to the myocardium. So you can imagine what problems can develop in somebody who has a situation like this. When we talk about infective endocarditis, most commonly this is going to affect the valves, okay? That's where a lot of the shear forces are occurring because you have that blood going across the valves. That's where they're going to be higher risk of, you know, little micro damage occurring to this layer because of those shear forces. However, it can then also affect any structure that is covered by endocardium. So that means your chordae tendineae, that means your papillary muscles. It also means the septum, the interventricular septum is prone to getting endocarditis. What can happen and what happens with endocarditis is you get this local trauma, you get this infection, you get this inflammatory response, and then it leads to the development of a vegetation, which you kind of think of as like a cancerous mass that starts to grow in that area and then can lead to problems down the road because it starts to interfere with normal function. When we talk about the classification of endocarditis, you can kind of describe it in 3 different ways. Some of these you actually will combine, so these are not just mutually exclusive kind of descriptions. You actually will see these oftentimes combined, and it just kind of gives you more detail as far as what's going on. So the first way that we define or describe endocarditis is how quickly this clinical course occurred. So was it an acute onset where they were fine and then all of a sudden they're very sick? And if we have that kind of clinical correlation, we usually will think of bad bugs causing that. So MRSA is a very bad bug, right? So it's a pretty aggressive, the clinical course for the infections of MRSA tend to be pretty quick. So if you have an acute bacterial endocarditis, be thinking MRSA. And it typically, because it is a bad bug, tends to affect healthy valves. And we'll talk about what a healthy valve is later in the lecture. If you have a subacute bacterial endocarditis, this is something that takes time to kind of evolve and develop. It may be that they just weren't feeling very good, maybe a little under the weather, but nothing that would make you concerned about them. And then the next day, they're just not getting better, not necessarily getting worse, and then it just lingers and continues on and continues on, and then they slowly get worse over time. So the case that Hannah McHugh from 24-1 had, this was the case. This person was coming and going to the ER over the course of 30 days. They just weren't feeling good and they weren't getting better before they decided to do the proper imaging to diagnose this condition. But because this is a very slowly progressive, we think of maybe not serious bugs that cause this. So we're kind of thinking maybe more like normal flora kind of bacteria that just happen to gain access to the system, to the blood, and started to propagate and lead to the infection. So strep species tend to be the common bug in this. So we're thinking like strep viridans, strep epididymis. So those kinds of normal flora bacteria that just happen to gain access to the right environment to cause problems. And because it's not an aggressive bug, for them to develop this condition, be thinking of somebody who is maybe higher risk of having it, like they have that proper environment to encourage this kind of infection. So somebody who has foreign bodies inside of the body, right? So a diseased heart valve, a valve replacement kind of patient. So you have a artificial heart valve. Now they're prone to having bacteria attached to that and then grow, replicate, and then cause problems. The second way to kind of classify it is what is the host substrate. So healthy valve means the valve that's normal functioning, you were born with it. It should be covered with an endocardium because it is native to you. Prosthetic valve would be, of course, they've had other valvular diseases and they've had a heart valve replaced with either a pig valve or replaced with a mechanical heart valve. And then, of course, you have IV drug use. So IV drug users tend to use poor septic technique, right? They either reusing needles, so they're getting exposed to lots of different things. They're not cleaning the skin properly. They're not prepping the substance that they're injecting properly in a sterile fashion. So these folks are going to be at high risk of developing some pretty nasty infections. And then, of course, the one that's probably most obvious is, well, what kind of organism is this? Is it gram-positive or is it gram-negative? Because that's going to influence the treatments for it, right? What antibiotics are we going to have to use for a typical gram-positive infection? What kind of antibiotics are we going to need to use to treat a gram-negative infection? Fortunately, when you actually look at the epidemiology of this disease in the US, it's a rare condition. And that's important because it's a pretty nasty condition to have. And we'll talk about kind of the mortality and the prognosis later on in the lecture, but the majority of folks die from this infection. So fortunately, in the United States, this is not something that's common, but it does affect 10 to 15,000 individuals in the US every year. It typically is going to affect folks who are male and older. And you may be wondering, well, why is that the case? Well, when we talk about the risk factors for developing it, you'll see you have to have other cardiac conditions, and then you have to have the setup for this. So male and older folks tend to have the valvular damage. They've either had a valve replacement that sets up that infection or puts them at high risk of developing this infection. And that's why it tends to be elderly males who get this condition. So you can get it community acquired, which if it's community acquired, similar to other things, community acquired tends to be less aggressive. So the most common bacteria that we're thinking is more along the lines of like the strep species. And it tends to affect the mitral valve most commonly. This also then, the second most common valve then in community acquired is the aortic valve. So the left heart structures are higher risk of developing this, which you may be wondering, well, why is that the case? Kind of makes a little more sense because there's higher pressures on the left side of the heart compared to the right, yeah? So now you're having more shear forces causing micro damage to the endothelium to set up a patient developing this condition. So that's community acquired. Healthcare associated, we usually think of really bad, nasty bugs with healthcare association, right? So we usually are thinking like staphylococcal species. Particularly MRSA. And to be hospital acquired, there has to be some kind of exposure to the hospital. So have they been admitted to the hospital? Have they had surgeries done recently? Looking for those kind of risk factors for healthcare associated. And then if they're an IV drug user, what's the stereotypical age of somebody who's using IV drugs? Usually more like 20s, 30s, right? So usually IV drug users are not going to fit into that high risk group of age 60 and older. It's going to be in the 20s and it's going to be in the 30s that folks tend to have this form of endocarditis. And because they don't use proper technique, they don't have sterile drugs that they're injecting, all that kind of stuff, they tend to get some very nasty bugs, to include like Pseudomonas and those types of things. But because they're injecting things directly into the venous system, it also tends to be more of a right-sided condition compared to a left. So we talked about community acquired being more common in the left heart structures. IV drug use, it's the opposite. It's more the right heart structures that are at risk for developing this condition. So tricuspid valve, pulmonic valve are the valves most affected with IV drug users. So what else are risk factors for this? So we already talked about the first two. We talked about structural heart diseases. So they have some other valvular condition that has caused damage to those valves, which then sets them up for an inflammatory response and to get infected. They have indwelling catheter. So this would be somebody who has like a PICC line of some sort for continuous antibiotic infusion. They have a hemodialysis catheter in place for a long period of time. Basically, the setup to kind of bypass the skin is that protective barrier to gain access directly to the vascular system and then cause that infection and cause that bacteremia. Poor dentition. So we talked about how community acquired is more common, commonly like strep viridans, and it tends to actually come from the oral cavity. So folks who undergo procedures with the dentist that manipulate the gingival tissue, you're almost creating a direct access of that oral flora, strep viridans, to gain access directly to the bloodstream and cause an infection. So poor dentition, dental type procedures tend to be a high risk for folks developing this condition. Now, I've kind of alluded to this, but developing this condition is not as simple as you just have bacteria in your bloodstream. If that was the case, we would see the number of new cases every year be significantly higher because we have so many admissions to the ICU in the United States for sepsis, right? So if it was just as simple as there's bacteria in the bloodstream, you're going to get this condition, then we would see probably 100, 200, 300,000 cases a year. But we only see 10 to 15,000. So that tells you that this is a more complex kind of condition on how you get it. And it really occurs in 4 steps. So we talked about how you have to have some kind of injury to the endocardium. So that micro trauma from the shear forces being there. Is there other things going on like IV drug use that's causing damage to the heart valves? So you're going to get that injury. Your body's going to sense that there is some kind of damage that has occurred, and it's going to try to heal it. So it's going to send a clot to that area to try to heal it. So you're going to get things like fibronectin, fibrinogen, platelets, all those kinds of things to try to heal the injury that has occurred to the endocardium. Well, now that that injury is there, and now you have that healing process going on, well, now this has created a good environment for bacteria to be, if it's in the blood, so you have that bacteremia, it's created a good environment for that bacteria to leave the bloodstream, gain access to that thrombus where that healing is occurring, and now it's protected, the bacteria is protected, and it starts to grow, it starts to replicate, it starts to get larger, and also tends to make it a much more complex kind of thrombus, and you develop this thing called a vegetation. And because you have this very complex thing in there, antibiotics have difficulty getting through this area and killing all of that bacteria in that vegetation. So this is one of the reasons why it is so difficult to treat this kind of infection. Now, one of the complications we're going to talk about is embolization. And you can imagine with this next picture that we see here, why this might be a problem. So what are we looking at with this? So I have a heart valve. You can see it's open. It's not closed, right? It should be closed because you do have air pressure that should be acting on this. But because you have this very complex kind of vegetation here that's growing through that heart valve opening, it's not allowing the valve to close. So that's going to disrupt the function of the heart. But then you also can see, why is this person a setup for this? Well, I also see some sutures, so this tells me that this patient had a heart valve replacement of some sort. Looks like a biologic, like a pig valve that was replacing another valve for some reason. But you can see, like, you got this little frayed kind of appearance on this vegetation. We talk about the shear forces causing the damage. What are the chances that those shear forces of blood going across that vegetation and causing little parts of that to break off and get sent downstream? So pretty high, but what are the secondary effects going to be if I do have these small embolizations breaking off and getting sent downstream? It kind of depends, where does it go? What organ is going to be impacted? What region of the body is going to be impacted by that? So, and we'll talk about some of the complications related to that. So, if this is a difficult disease to get, it's a rare disease to get, how you as a provider, how and when should you suspect that a patient of yours has this condition? A lot of times the symptoms could be very vague, especially if it is like that community acquired that takes a long time to kind of evolve. So you're kind of looking for things that just don't make real sense. So prolonged fever. So you have a patient that comes in, they have a fever, okay, great. Things like flu and some of these other things, they usually will stop having fevers within 48, 72 hours or so without the need for medicines and stuff like that, right? But what happens if that patient continues to have fevers for a week, 2 weeks, 3 weeks? That's not a normal process for a patient with a normal, common kind of infection. So be suspicious of somebody who has a fever that lasts longer than a normal infection should. If they start to present with weird kind of evidence of like emboli, septic emboli, so they start having like strokes in the patient that doesn't make sense to have a stroke. If they start having limb ischemia, other kinds of things that just don't make a whole lot of sense, then be suspicious for this. Another patient would be you have them in the hospital, you have blood cultures, you know what the antibiotic is, you know what that bacteria, you know what the bacteria is, you know what antibiotic they should be on, and it's sensitive, and you have them on that antibiotic, but they continue to have positive blood cultures. It tells you that something is protecting that bacteria from the antibiotic that you're giving them to the point where they just don't get better. They continue to have that positive culture of that bacteria in your blood cultures. And then if you have anybody who's high risk for developing infective endocarditis, so they have prosthetic valves, they're IV drug users, those are all things, and they're presenting with a fever, be suspicious for infective endocarditis. But to help us with the diagnosis, we do have a set of criteria to help us differentiate those who probably have it or they definitely have endocarditis. It's called the Dukes criteria or the modified Dukes criteria, and that can help us with it. So I don't expect you to memorize all of this, but I will expect you just to know what the different criteria mean as far as if they have 2 majors, 1 major, whatever. Is that somebody who has a confirmed definitive endocarditis or maybe possible? So what makes them definite or definitive? They have 2 major criteria, or they have 1 major and 3 minor, or 5 minor. So if they have those, and we'll go on the next slide, shows you what your majors and your minors are. But if they meet that, then they have definitive infective endocarditis. If they only have 1 major and 1 minor, or they have 3 minors, so you don't meet that criteria for definite, then it's still possible that they have infective endocarditis. And then if they don't meet this criteria, then you can reject infective endocarditis as a potential cause for their condition. So what are the major criteria? Well, positive blood culture for infective endocarditis. And this is going to be looking at typical bacteria that cause infective endocarditis. So we talked about Strep viridans. We talked about Staph aureus. But it could be things like Enterococci or Enterococcus. It could be Strep catalyticus. So there's a number of different types of bacteria that are higher risk of causing infective endocarditis. If they have a persistently positive blood culture, so we kind of talked about that. If they have evidence of endocardial involvement, so that being another major criteria. So if you do an echo and you see a vegetation, it doesn't matter what else they have as far as number of symptoms and other criteria because they have infective endocarditis, right? So if you see a vegetation, then they have infective endocarditis, or they meet at least a major criteria for infective endocarditis. And then another one is they have a new valvular regurgitation. So this is somebody who normally when you listen to their heart, they don't have any murmurs, and then they come in and now they have a new regurgitated murmur, then be suspicious for infective endocarditis, because maybe that vegetation that is growing on that valve is interfering with the closure of that valve. And then our minor criteria, this is why you need 5 of these if you don't have any majors, but you need 5 of these in order to have definite infective endocarditis, because these are very vague kind of symptoms. So they have a predisposing heart condition, or they're intravenous drug users. They have a true fever. They have evidence of a vascular phenomenon, which we'll talk about. They have immunologic phenomenon. They have microbiologic evidence of positive blood culture, and echo minor criteria are eliminated. So you're not, on the echo you're not really seeing that true vegetation, but you're seeing kind of those other things. So when you are evaluating a patient that you are suspicious has infective endocarditis, of course it's going to come down to history and physical are going to be important, right? We talked about how you should try to make your diagnosis based on history and physical. So take a very good detailed history looking at the risk factors for that. So are they IV drug users? Have they had surgery or valvular replacement surgery done that would then make them high risk of developing this condition? What symptoms are they having? Just the simple things for the history. For the physical, definitely taking the time to listen to all of the auscultatory sites, looking for a regurgitation kind of murmur, because that could suggest that vegetation is there and it's interfering with the closure of that valve. So looking for that new regurgitant murmur with a fever, be highly, highly suspicious for infective endocarditis. Then you are going to need your ancillary studies, so let's do our blood cultures to see if we do in fact have a bacteremia, what is causing it, what is it sensitive to, so I know how to treat it. Chest x-ray, okay, there's some benefit to doing that. And then an echocardiogram, of course, is going to be important to actually visualize what's going on in the heart. But when you have a patient who is presenting with infective endocarditis, when we break down what are the common symptoms or what is the incidence of having these symptoms with somebody with infective endocarditis, we actually see that the most common thing you're going to find is actually a fever with that new murmur. So in 80+% of patients, those are going to be the 2 most common symptoms that they're going to experience. The things that we normally think of as pathognomonic for having infective endocarditis, so like your Janeway lesions, your Osler nose, those kinds of things, you can see these are actually pretty rare things in somebody with infective endocarditis. So the things that we see that we're like, oh, this person has this, aren't very common. So you can't use the absence of these physical exam findings to reassure you that they don't have this medical condition. Other things that may bring them in, because, yeah, how many times do people have fevers and never go to the doctor? And some of those other kind of vague type of symptoms. So what could bring them in? Well, it could be that they start to have complications related to that vegetation or parts of that vegetation breaking off and getting sent downstream. So they may start coming in with cardiac conditions. So things like now they have a new heart failure, or they're coming in with palpitations, or maybe sudden cardiac death because of a sudden development of an arrhythmia because of that vegetation growing into the wall of the ventricular septum and disrupting the conduction system. It could be that they have a piece of that that vegetation breaks off and gets sent up to the central nervous system, and now they're presenting with a stroke. That could be what brings them into the ER. It could be that part that breaks off of the vegetation goes to other areas of the body, other organs, and now they're coming in with that organ failing and not cooperating properly. So like kidneys, maybe it's the lungs, because they're an IV drug user and now they're having those emboli going up into the lungs and causing septic emboli. It could be that it's going to go to the bones, and now they start having these weird like osteomyelitis or bone pains and those kinds of things, because now that has gained access to the bone, and now it's starting to kind of eat away at the bone and cause pain and stuff like that. So they could come to see you when they start to experience complications related to this disease. So how are you going to evaluate them? Well, you're going to do the typical infectious kind of workup. So you're going to get the CBC to look at their blood count. You're going to get blood cultures. Ideally, you want to get blood cultures before you start them on antibiotics, because you don't want to get a false negative result because of that antibiotic is there. And you may be wondering, well, if I just started to infuse this antibiotic, why does that matter? Hasn't been in there for a couple of hours. Well, the reason is I take that blood sample that I just took, I then throw that into the incubator, and it may be that it was only there for a little bit, it hadn't had that time to kill that bacteria, but in the body, the human body, but in the incubator, it's going to sit in that sample, and it's going to prohibit or interfere with the growth of that bacteria. So it could be that you get a false negative result. So try it anytime you're doing cultures for anything. Try to get the culture sample done before you give them any kind of antibiotic to treat. You are going to want to get an echo. You may want to start off with a transthoracic echo because it's minimally invasive. I don't need sedation. These patients could be pretty sick by the time you're seeing them, right? So try to do a transthoracic echo. This can pick up on large vegetations, but if you don't see a vegetation and you are suspicious for infective endocarditis, go ahead and get a transesophageal echo when the patient is stable enough to be able to visualize that vegetation. The sensitivity is much better with a transesophageal echo when you compare it to a transthoracic echo. This is a complex algorithm. Basically, it boils down to get a TTE. If you don't see the vegetation, but you still are suspicious, go ahead and get the TEE to evaluate further. Okay. So we talked about, so there may be some additional physical exam findings that are highly suggestive of infective endocarditis. But we talked about how only about 2 to 15% of patients actually present with these findings. So what exactly are they? They're split into two big categories. So you have your vascular phenomenon findings, which include things like Janeway lesions. But these are conditions where that vegetation, small parts of that vegetation are breaking off and getting sent downstream and blocking the flow of blood in the tiny, tiny vessels, okay? So these wouldn't necessarily be like the stroke. It could be very tiny findings that you see, and we'll show you examples of like the Janeway lesions here in a sec. Then you have the immunologic phenomenon, which is, this is the immune system's reaction to the condition. So the immune system kind of goes erratic and starts causing problems to other structures, other organs because of this. So what are vascular, or what do Janeway lesions, which is a vascular phenomenon, look like? So it's just kind of this erythematous spot. The key kind of distinction to this is these are painless spots. You can get splinter hemorrhages, so little parts of the vegetation break off, get sent to the small blood vessels, and you can actually see this in like underneath the nail beds. If you have an IV drug user or somebody who has right-sided infective endocarditis, then that stuff that breaks off can get sent to the lungs, and now you start getting septic pulmonary embolism, or sorry, septic pulmonary emboli. And then now we're looking at the immunologic phenomenon. Rot spots affect the retina. You can see it's like this central clearing with this like halo appearance of erythema around it. This is a much more serious case of it, but kind of more commonly like this, where you just see this erythema, this reddening of the digits, and these are painful. So kind of compare that to a Janeway lesion, which is painless. These are painful. So that's what you can see on physical exam. So what other ancillary studies do you want to get? Well, let's do a chest x-ray. Let's make sure there isn't any kind of pulmonary septic emboli. Let's get an EKG. Let's see what their conduction system is looking like. Let's see if there is any evidence of heart blocks or bundle branch blocks present because of the vegetation growing into the walls and affecting the normal conduction system. Let's do urinalysis, because a lot of times this emboli can break off and go to the kidneys and disrupt the function of the kidney. This is an inflammatory condition, so you're going to have elevations in your acute phase reactants, so your ESR, CRPs are going to be elevated. So those are the pretty typical workup for folks with infective endocarditis. Now, when you get your culture, it could take you 48 hours for you to get results back, especially the sensitivity part to it. So what am I supposed to do as far as my antibiotics of choice while I wait for that 48 hours to happen to get the definitive data? I don't necessarily shotgun them with a broad spectrum antibiotic, because is this gram positive? Is it gram negative? Is it staph species? Is it strep species? The antibiotics you choose is going to be very different depending on which bacteria or kind of bacteria you are trying to treat. So knowing, based on your history, what makes that person high risk for having this condition will tailor the antibiotic of choice. So if I have somebody who's an IV drug user, you can see the most common cause is going to, bacteria that cause this is going to be MRSA. But it could be Pseudomonas. It could even be yeast that's causing this condition. So You're going to have to tailor your antibiotic choice depending on the risk factor. If I have an older patient who has a native valve, typically, okay, think of this patient as getting this because of a dental procedure, you're going to want to get antibiotics that treat strep viridans. That's what is most common for that. If you have hospital acquired, then you're going to want them on antibiotics that treat MRSA. If I have a prosthetic valve, then staph epidermidis. What's interesting is if you have a culture that comes back with strep gadalyticus, this actually could be the initial presenting signs of colon cancer. So they may not know they have colon cancer, but this bacteria shows up in their blood culture. Then you should be highly, highly suspicious for colon cancer. And as soon as they are stabilized, they're getting a colonoscopy to evaluate for that cancer. So how do you treat it? I'm not going to expect you to memorize the treatments, which antibiotics you choose, because this is going to have to be something you look up based on the patient's risk factors. Based on why you're suspicious that this patient has this condition, that's what's going to impact your choice of antibiotics. So you're going to get those blood cultures. You're going to start them on a broad kind of empiric antibiotic treatment for the suspected organism while you wait for those cultures to come back. These patients are going to be very sick, so they're going to have to be admitted to a critical care unit, whether it be a cardiac critical care or an ICU. These patients you should not be managing on your own. Now, as a primary care provider, you're never going to be managing these patients on your own. But if you are working in the hospital floors admitting patients, this should not be somebody you are taking care of primarily. You're going to need a team of experts to help you. So things like infectious disease, because they're going to help you with the antibiotic regimen for this patient. Cardiology, so they're going to be doing the echoes, but they also are going to be monitoring the function of the heart. Is this condition affecting the heart function to the point where maybe we need to kind of add some additional medications to treat like heart failure? And then cardiothoracic surgery should also be on board, because if there is a large vegetation there, then you may need to go in and get rid of it via surgery, kind of a source control kind of thing, where you can throw as many antibiotics at this thing, but if that vegetation is still there, you still have the source of the infection there, this patient will not get better, or is unlikely to get better without surgery. Let's go ahead, let's take 10 minutes, then we'll come up and we'll finish up. The Facebook page for IPAP. Yeah. Did you see the post from Colonel Jones with the Army folks? Yes. So one step closer for commissioning for the here. So Coast Guard is the first service to do it. Their new class coming in 26-3 actually will be commissioned. Of course, that was a mistake. They jumped the gun when they got it, but Army looks like they're following suit. So hopefully they'll get you guys commissioned on arrival. So, all right. So getting back to cardiology, so we just talked about kind of the interdisciplinary team that's required to manage these patients, because they are going to be pretty sick, and it's a very complex kind of condition. But one thing we ought to know is when we put them on antibiotics, what's a typical course of antibiotics we give a patient? Maybe 5 to 14 days, right, in that range. If you do that, you're going to fail your patient in treating this. Because if I have to get rid of every single bacteria inside of that vegetation, you can imagine it is going to be extremely difficult to kill every one of these little purple ellipses, right? So these folks are going to have to be on antibiotics for a long period of time. So at a minimum, 4 to 6 weeks. Now, they may extend that longer depending on how they're feeling and everything. And these are not oral antibiotics. These are IV antibiotics that they're going to be on for this extended period of time. So they're not going to be on just a regular peripheral IV. They're going to have like a PICC line, something that can be indwelling for an extended period of time, which in and of itself carries risks, right? So they're going to need to be on antibiotics for a long, long time. So what complications could develop? What should we be watching out for even after we have started treatment, right? We normally start somebody on a treatment plan and then say, okay, let's follow up in a month, let's follow up in 2 weeks. We can't do that because they are going to be prone to developing a lot of different complications even after treatment is started. So what we need to be on the lookout for is chips breaking off of that vegetation and getting sent downstream, even if it hasn't happened by the time they come and see you. They could start to develop heart failure, so monitoring the status of their heart and its function. They may start to develop abscesses in other locations. Just because we're watching that vegetation, it doesn't mean that some of the bacteria can get to other parts of the body and then cause abscesses to form. So you're going to need to monitor for these complications. And ultimately, these folks need a dental evaluation. If the most common cause in the US is a dental source, does it make sense that we probably need a dentist to come in and have look at their teeth to see, do they have like a root abscess or something going on, some kind of gingival disease that's putting them at risk of developing or getting that bacteria into the blood and seeding the blood. So have a dentist come. Maybe they're going to need some teeth pulled to decrease the chances of this being an ongoing problem. But the prognosis for this is actually pretty poor. Usually folks will have a relapse about 2 months or 8 weeks after treatment was started. You may be wondering, well, why is it 8 weeks? Well, we just stopped antibiotics 4 to 6 weeks after treatment, you know. So it's going to take some time for that bacteria that maybe we didn't get rid of to kind of rebound and become to start growing and everything, and then start causing problems again. So that 2-month mark, we have to be very careful of. That's typically where that relapse is going to occur. Especially if the reason they have this is because they have a prosthetic valve, or they're an IV drug user who continues to use IV drugs. If you develop this condition once, then you're probably at high risk of having it happen again, right? So you have to be careful around this 2 month for a relapse. And the reason we are concerned about this is the mortality rate associated with this condition is so high. So even after we've admitted the patient, they've started treatment that is empiric and will take care of the bacteria that is there, their in-hospital mortality rate is up to 1 in 4.
Why can we give lifetime antibiotics the same way we do with the more compromised people with AIDS or HIV?
So like, could we extend antibiotics for longer?
Yeah, like for the people who have prosthetic valves, why don't we give lifetime antibiotics the same way we do with HIV or AIDS in this case? They get lifetime antibiotics because they are like higher risk of acquiring
for like pseudomonas, or PCP or whatever the name for it is.
Yeah, why can't we do the same for a prosthetic valve if they're on a higher risk?
The answer to that is, as long as they're not doing other risky things like IV drug use, we tend to give them prophylactic antibiotic before they go get a dental procedure done. So we can kind of take care of it right at that moment. Because the risk of this, getting this condition, usually there is some other thing that maybe we can control it a little bit. Now, if they are IV drug users and they're refusing to stop IV drug use, then that might be a discussion to have as far as, okay, you're going to continue, that's fine, but you're going to need these antibiotics now to prevent you from getting sick and stuff like that. So, but we'll talk about like rheumatic heart disease in block 3, and we do give prophylactic antibiotics for years after somebody developing rheumatic heart disease. So there are certain situations where we can't do that. So 6-month mortality, even after you got treatment and you were deemed treated, again, upwards of 27% mortality within 6 months. The mortality rate, if it's fungal or pseudomonas, so seriously bad bugs, upwards of 50%. And then, of course, if we don't diagnose this quickly, then the mortality rate can get up to 100% pretty quickly. So it's important to have this high index of suspicion for this disease with patients who are just not responding to treatments, or just something's a little weird, something's a little off with it. So kind of going back to the prophylaxis thing. So what we have done and what we do recommend is if you have a patient who is high risk of getting infective endocarditis, which includes patients who have prosthetic valves, it includes patients who have congenital heart diseases that are not fixed, which we're going to talk about congenital heart disease on Monday when we meet again. Folks who've had an endocarditis infection once, those are folks who are going to be high risk of developing it again in the future if they're put in a position where they have a high risk something that's going to cause an infection again. So for dental procedures, especially dental procedures that manipulate the gingival tissue, these folks should be on a prophylactic antibiotic before that procedure occurs. And when you go to a dentist, that's one of the questions you have to answer is, do you have any of these conditions? Have you ever had endocarditis before? And this is why, because they don't want to touch your teeth, your gums, your anything until they can verify that you don't have to be on some form of prophylactic antibiotic. But there is a set criteria for who would benefit from prophylactic antibiotics and those who don't. So what do we use for prophylactic antibiotics? It kind of depends on your patient. We see if they have any allergies. You have to see if they can actually take pills. If they can, great. If they can't, then they need to look for IV sources. But you're going to tailor it to what your patient can and can't do and if they can tolerate it or not. But typically, most folks will do well with taking amoxicillin, like 2 grams of amoxicillin. And that's all that they really need in order to provide that prevention. If they are penicillin allergic, then you could do cephalexin or Keflex, as long as they can tolerate the cephalosporin, meaning like their allergies, like a rash, not the anaphylactic version of penicillin allergy, or even a macrolide. So you've got a number of kind of different options that you can give to these patients. And then let the dentist kind of determine if they need to be on continued antibiotics even after the procedure is done. This is something that a primary care provider will do. So you'll have a patient who will come in and they'll say, my dentist said I need antibiotics before they do the procedure. So this is something as a primary care provider you will have to do. But coordinate with your dental colleagues and see, do we need them to be on antibiotics even after the procedure? Okay. So let's go back to the case that we started with. So if you remember, we talked about how the patient started to have these weird rashes developing on her hands and her feet. So you'll see, we said that the rash on the left-hand side was painless, and the one on the right was painful. So as you can predict, as we talked about, the one on the left are Janeway lesions, so these are painless lesions. So this is a vascular phenomenon. The one on the right is a Osler node, because it was painful, and it's an immunologic phenomenon. And then these little red dots were petechiae, because her platelet counts were just dropping. And she got down to 40,000, less than 40,000 platelets. Normal is like, what, about 150,000? Got to the point where we were concerned, because I think we only have 1 unit of platelets at Belvoir, because platelets they expire pretty quickly, so it's hard to keep a large number of platelets on hand. So I think we only had like 1 unit of platelets, so if we had to transfuse, we were going to quickly deplete the hospital's source. So anybody coming with like a massive hemorrhage would not be able to get platelets as part of their massive transfusion protocol. So that's what developed. So I ended up calling the infectious disease doc while he was driving into work in DC traffic, and he became concerned because at this point we didn't have our own antibiotics because we thought this was a COVID infection, right? That was just causing like a septic kind of picture. But he recommended go ahead and start vancomycin and Zosyn to kind of do the normal septic sepsis treatments, and then said that he would go see the patient as soon as he got here. So he got in, he started looking, started evaluating. He's like, she meets the criteria for toxic shock. Normally you think of toxic shock as from like tampon use, right? And he's like, well, where's the source coming from? Well, your medication reconciliation is important, right? So she was postmenopausal, didn't like the postmenopausal symptoms, was on an estrogen vaginal ring to provide some kind of hormone to help her. And the vaginal rings are allowed to be in for 90 days. She was at 91 days of having that ring in. And the only reason she didn't replace it on time was because she was feeling so sick the day before that she didn't replace it. So she developed toxic shock from this vaginal ring. Well, that bacteria got into the bloodstream. It caused some damage to the heart valve, and then she developed the infective endocarditis. So now she has 2 different conditions, and when we finally got the speciation of the bacteria back, it was methicillin sensitive Staph aureus. So not as bad as MRSA, but maybe not as good as strep species, right? But she also was not a candidate, or she wasn't at risk of strep species because she didn't have any valvular disease, right? So she had a healthy valve. So we consulted cardiology. They came and saw her. They did a transthoracic echo, and they did not see a vegetation on the transthoracic echo. So they said, treat her like it's infective endocarditis. You already have a speciation. Got the sensitivities coming back tomorrow. Continue treatment. We don't want to do a transesophageal echo because her platelets are a little too low. And we don't necessarily have the platelets to transfuse to get her back up unless there's an indication we have to do that. So we continue the antibiotics. Her cultures continue to be positive for the same species. A week goes by, she's still having fever, she's still having an elevated white count. Her thrombocytopenia persists. It kind of stabilizes, I think, about 35,000. And we finally are just kind of getting so fed up with not knowing what's going on, and cardiology didn't want to do the TEE. They just said, continue antibiotics. Well, in this time, she started to develop musculoskeletal pain. We're like, okay, what's going on? This is a little weird. Is it just from sitting in bed for long periods of time? She'd been admitted to the hospital for a week, and hospital beds, we all know, are not very comfortable, right? So we ordered a couple of x-rays of her shoulder and her knees. Everything came back normal. So we decided to get a PET scan. Since we couldn't get a transesophageal echo, we got a PET scan, and you can see on this, yes, the bladder should highlight up, the IV site should highlight up, and the brain should highlight up, but every other black spot is a septic emboli. So when we talk about this vegetation and things chipping off the vegetation and getting sent all these different places, that's how debilitating it could be. So what did we find? There was a 1.2 centimeter, 1.2 centimeter vegetation on the mitral valve that was evading the ventricular septum. We found, ophthalmology came up, they looked at her retinas, they found Roth spots. They also started to notice some kind of other things. The septic emboli had invaded the bone and was eating away at the bone, which is why she was having hip pain, which is why she was having knee pain, because of those septic emboli that basically was causing like an osteomyelitis. But based on the size of this vegetation, she qualified for surgery to get the valve replaced. Because that vegetation was so large, you had to remove it surgically. So she got transferred up to Walter Reed because they had the cardiothoracic surgeons there. We didn't have them in Belvoir, and she underwent a valve replacement. They did have to take out some of the interventricular septum, so they had to put some artificial patching on that side to kind of re-strengthen up the wall based on what they had removed because of that vegetation invading the septum. I lost kind of track of her, unfortunately, about a month after she was discharged, but she was still alive at the time, but she was still on IV antibiotics and was still having a lot of symptoms, a lot of pain, and those kinds of things because of it, unfortunately. So, so something as simple, as like a normal thing to treat, postmenopausal symptoms could lead to pretty serious conditions. So, questions? All right. We have now accomplished one thing off of our PANTS blueprint that we had to talk about, so we're making progress. So, I will see you all on Monday. I think we're talking about